about the video? I kind of liked it. Like I said, I came from a very special unit that started doing a lot of mobility work early on. And I'll kind of talk about that in a little bit. But it was part of the day. It was part of us. Every patient, we tried to get the sedation off, we tried to walk them. And it was great to see the outcomes. As you saw, most of them went home. They went home functional, might have gone home on oxygen, might have gone home with PT, but they didn't spend weeks on the floor. They didn't go to sniffs. You know, it used to be that's what we would do, and we'll kind of talk about that. The goal of ICU was just to make them survive. But the goal of decreasing delirium, the goal of mobility is actually to let them be humans, let them get home and get back to that same functioning level they had been. Margaret Harris is a critical care physician and researcher out of Canada from the University of Toronto. She started doing a lot of work with ABCDES, and I really love this quote that she had. That there appears to be significant potential for harm arising from the current ICU culture, patient immobility, and an often excessive or unnecessary use of sedation. This is a culture that began for all the right reasons, but the culture has persisted despite emerging evidence that these current practices may alone or in combination with acute illness that precipitated the ICU admission have important adverse consequences that may not be remediable over time. We need to change the management of these patients. Sedation is great. We used it. We started using it for the right reasons. We're always doing everything in medicine for the patient's best outcome. We're trying to do the best, but some of the stuff that we do can cause problems with them. It can harm them in other ways besides what brought them into the hospital. There's a lot of talk now. A lot is going on about ICU. You know, Mike has been suggesting to a lot of people to listen to a podcast, so we'll kind of get a link to that put up. But this was an article in the New York Times just this year, in April, just talking about my ICU patient lived. Is that enough? That used to be our gold standard. We used to care about they survived, we were successful, we shipped them off to a SNF with a trach and a peg, but they're alive, yay. There's a lot more now that we want to talk about the outcomes of these patients. And this isn't brand new. This is 2011, the Wall Street Journal started talking about the ABCDES, what we're trying to do to make the ICU outcomes better for patients, for their lives. So a lot of the things we're looking for is the quality of life. As providers of critical care, we must realize that survival is no longer the gold standard outcome that we focus our energy on. The things we choose to do or choose not to do have long-term effects on the lives of patients we serve. You know, I love that video. Two of the women in that video that I shared, one was pregnant, one had just had her baby, and they had stuff to do. They got life to live. You didn't notice Kennelly, the blonde. She's a real little one. We coded her, I don't know how many times, 3, 4, 5 times. And her husband basically moved in. We brought baby in. It was kind of crazy while she was still kind of out of it. So she was a focus for a lot of us on the unit. We wanted to make sure she could go home and have that family. And she actually has 2 more kids, doing great. Sorry, back to this. Because we don't see those effects doesn't mean they aren't real, or does not mean they're not our responsibility. Post-ICU syndrome, it's a big deal. So it has effects all over the place. One part we talk about is families. They have to deal with it. They're coming in. We see these families that are going through grief. They have PTSD, depression. But the patient, the survivor, is affected in many ways. Mental health, cognitive, physical impairments. Delirium has a lot to do with it. They're all intertwined. Mike was talking about delirium and, you know, huge effects on anxiety, PTSD, depression, also cognitive function, memory, attention, all these things. So what we're doing now to treat our patients and keep them alive actually is affecting them much further along. There's a lot of work going on right now with the post-intensive care syndrome. There's a lot of facilities that are actually creating clinics for this. They're trying to do a lot of work with it. But I think a lot of this can be done up front. It's great to take care of after the fact, but it's better if we can avoid some of these things. Some of the physical issues that we have, that we see about ICU and weakness. You know, these are kind of anecdotal, but when I tried to hold a cup, I spilled it on my bed. I couldn't brush my own teeth. I could not comb my hair, and I wasn't able to pick up the covers and move them. Another, I could barely move. I would try to walk across the room, but I had to sit down. I was so tired. I'd rest in a chair, then on the couch somewhere else. It took me forever to get anything done. You know, people before their illness were living a normal life, were contributing to society, but their illness, everything else that's going on has affected them. And I'll kind of show a little bit more of Margaret Harris's study. Is she got to follow them 1 year after, 5 years after. So you have long-term effects. But why? So I was fortunate enough a couple months ago to go down to Oregon and go on a mobility conference that was there. And it was great. We had one of the physicians from the University of Washington was able to present, Dr. Hogue. And she talked a lot of it about what's happening with the nerves and muscles. So when you're in a critical illness, you have nerve dysfunction, denervation, muscle atrophies, myopathies, loss of strength, loss of force, the pathogenesis. Bacterial toxins cause problems. MODS, multiple organ dysfunction, has inflammation, oxidant injury, metabolic derangements, drugs, inactivity. So a lot of things are happening and affecting negatively the nerves and the muscles. When we look at the atrophy of muscles, so we're looking at time and days, what's going on, single organ failure, multi-organ failure. So this study was looking at the change in the cross-section of the rectus femoris, and just look at 10 days, the drop, you're losing 20% of your muscle. If this patient came in with multi-organ failure, and a patient with just single organ failure is losing about 7% of their muscle in that time. So just lying in bed for a week is, patients are just wasting away. Weak patients have worse outcomes. So increased duration of ventilation increases, you're going to have longer time on the ventilation. So 1 to 3 weeks if you have weakness. It's the most significant predictor in prolonged muscle weakness and mechanical ventilation. Longer ICU and hospital stays. More likely to be re-intubated. They're the ones that are failing their trials. Less likely to go home and hospital discharge, going to rehabs, going to SNFs. More likely to die in the hospital, and they experience delays in rehab. It takes them longer to get their strength back, to walk, to work. Especially we're seeing a lot more of these obese patients. Every day, they're strong patients. They're carrying around a lot of weight every day. But think if they lose 20% of that mass, they can't even walk themselves compared to, you know, the little tiny grandma that doesn't need as much of her muscle mass to do it. These guys physically can't walk and have to start all over again. So it just has a lot of poor outcomes on patients and on their life. So back to Margaret Harris, so 1 year survivors. So survivors in the acute respiratory distress syndrome have persistent functional disability 1 year after discharge from the ICU. Most patients have extrapulmonary conditions, but the muscle wasting and weakness are the most prominent. So it's not necessarily just the pneumonia or the sepsis or whatever it was that caused the initial problem with the ARDS, but that muscle wasting. They still have problems breathing due to the muscle wasting. Risk factors for the ICU acquired weakness is the clinical illness itself. What brought them here? Sepsis, SIRS, multiple organ failure. ICU medication, so there's a lot of thought, maybe risk factors. Some newer studies though are looking at neuromuscular blockades and steroids, and they're looking that the neuromuscular blockades are not significantly associated with recent ARDS, and steroids not significantly associated with neuromyopathy. So we are giving drugs, but now we're starting to see maybe that's not the biggest cause of the problem that we used to think. Other potential modifiable risk factors are blood transfusions, fluid, and duration of bed rest. So immobility, it's bad for the whole body. Dale Needham does a lot of work on immobility as well as Peter Morris. And so looking at some of their studies, the effects on muscles, we've talked about atrophy, decreases strength, loss of mitochondria, effects on metabolism, increased insulin resistance. You know, how many of our patients need insulin when they're not diabetic before they came into the hospital? Decreased protein synthesis and fatty acid metabolism, cardiovascular effects, so baroreceptor dysfunction and orthostatic intolerance, decreased contractile length, strength of the myocardium, and inflammation. So has problems on the muscular system and on neutrophil migration to the lung. This isn't new though. So this wasn't just like, oh my gosh, we just figured this out. You know, this is back in 47, the dangers of going to bed. So, just lying in bed isn't that good for you. So there's a lot of things that affect the outcome of an ICU patient. We talked about sedation and delirium. We all kind of know about sleep and mobility have huge effects. So this is a design created by the IHI, and it just talks about kind of the 4 things that go with it. Dr. Terry Clemmer is a physician I was lucky to work with. He worked with Intermountain Healthcare, but also presented on mobility for the Institute of Healthcare Improvement. The talk, you know, they created this diagram to see where everything affects. We know sedatives affect mobility. Your patient's asleep, we're not getting them up out of bed, we're not moving them around. That's PT. You come up, you're like ready to go, and they're on a drip, and they're out cold. What's that affect? You're like, okay, well maybe I'll try to come back later. You got a full schedule, you're working your tails off. That might not happen. We know, Mike talked about, it affects delirium. And sedatives are not real sleep. We're not getting real sleep. You may go, oh yeah, my patient was out for 8 hours last night, that's great. They're not getting the real rest that they need. Delirium, it affects sleep. You're not getting good sleep if you're delirious. And if they're delirious, we go, oh, they're crazy, let's drug them a little bit. A little Ativan is going to help them a lot, calm them down, right? And delirium, a lot of people are like, my patient's hyperactive, they're a little crazy, I don't want to try to walk them, they're a fall risk. So sleep improves delirium. Good sleep actually helps mobility because they're awake now, they're actually able to work. And real sleep, you don't need those sedatives, so you're going to have positive outcomes there. Mobility decreases delirium, helps with the good sleep. You know, if you're working night shift, one of the best things if your patient can't really sleep, if it's safe, is get them up, get them moving, and they're going to get tired. In that video you saw some of those women were talking about how exhausted they were just from walking 10 feet or to the next room. Tire your patient out physically. Then you're going to have a pretty good night when they're actually sleeping. And, of course, less needs for sedatives. Wesley Lee has done a lot of work with Vanderbilt about the ABCDES and started talking about them. So, to recover from critical care, we want to talk about awake and breathing trials, coordinating and choice of sedation, delirium monitoring, management, early mobility, and exercise. Recently, they've increased it. And if you guys want to learn a lot about delirium, just go to the ICUdelirium.org webpage. Lots of great stuff, lots of great videos, a lot of patient interviews also that I'd love to look at. They talk about the effects that they have, what happened in the ICU. So these are the new ABCDES. So assess and manage for pain. So we want to talk about pain. Maybe that's their problem. They don't necessarily need sedation, but they need some pain management. Both spontaneous breathing trials and awakening trials. So turning that sedation off. Let's see how it goes. Turn the probe off. If you got to turn it back on, remember how we do a awakening trial. We're going to put it half. If they need more, yeah, up it a little bit. But try to wake them up. Choice of sedation and analgesia. We had a nice talk about Mike on that. What's the good way to do with it? Delirium monitoring and management, early mobility, and a big thing, family engagement. And I'm really excited about the work we're doing here in the unit. We're talking a lot about coming up with these diaries, so we're involving families. Our rounds is helping include families and what's going on to talk about everything. So it'll be really good. Just give a little background on me. So I actually was a nurse once. It was kind of cool. I liked it, bedside. I was lucky enough to started working as a brand new grad in the respiratory special care unit, which became the respiratory ICU. It started at LDS Hospital in June of '99. What happened is a lot of the staff that worked in the shock trauma ICU, the medical ICU, started talking about their patients. Specifically, there was one young man that came into the hospital. He was in ARDS. He was not a trauma. I think he just had a pneumonia and they developed an ARDS. Well, they were doing a trial at that time doing echo. Echo is kind of like ECMO, but it was bigger machines, bigger lines. It was kind of crazy. It was a 2 nurses to 1 patient type of setup. He was one of the lucky guys to get put on echo to get this pulmonary bypass. So biggest thing, we're worried about these huge lines, about bleeding, everything that could happen. So they paralyzed the crap out of that patient. Sedate and paralyzed, you do not want him moving. We're trying to rest everything anyway. So success story, he survives, does well, gets out of the ICU, goes to wherever rehab. Months later, my old boss and mentor said this guy comes in a wheelchair, this young guy. Didn't recognize him, of course. We don't know what our patients actually look like because they're totally different, but they're looking like in the ICU. And found out who he was, started talking, and she was like, oh gosh, that's great, you survived, you're doing well. But it was gnawing at her, why in a wheelchair? Well, all the paralytics created neuropathies. So months later, this young kid is not walking on his own, still going through all this rehab. And they're going, we did this to him. What can we do to get better outcomes? How can we not do this to someone else? You know, and the patient, he's like happy to be alive. He's like, I was teetering on death, just like the women in the video, like, wow, I'm alive, that's great. But the caregivers are going, yeah, you're alive, but we put you in a wheelchair, at least for the moment. You know, he was able to get out of it later on. So they wanted to start working on it. They wanted to see what can we do different. There were not a lot, in the 90s, there's not a lot of studies out there dealing with mobility, moving patients, waking patients up. So they created a special 8-bed unit, and they started looking at patients that came from other ICUs, the failure to weans, the ones that just couldn't get off the vent, and started working with them to try to get better outcomes for them. In 2008, it moved into a brand new hospital. They built a whole new campus, and you know, just as when it was LDS Hospital, and then when it was Intermountain Medical Center, the respiratory ICU was there. It's a Trauma 1 tertiary care teaching academic facility. So they actually got a lot of support. It's kind of crazy to get the support in the hospital. Just said, hey, here's a unit, why don't you start it, do these great things. Not going to find that a lot anymore. Can't get a lot of research going that way. So they went on to publish. They first published in 2007 about mobility, but they started the work back in '99. So my mentor and the manager I worked for, Vicky Spuler, and Dr. Terry Clemmer, actually became faculty for Institute of Healthcare Improvement, IHI, and would go all over the country and talk about early mobility and the work they did. We had a conference at our hospital in 2011, and based on the ABCDES, Wes Neely from Vanderbilt went there. I had a great opportunity. So I started as a bedside nurse in this unit, then I became the educator, then I became the manager. And I got the opportunity to kind of talk about the whole delirium and the CAM scoring with Wes Neely to all these people that came to the conference. Kind of cool. But I had to throw this out. This was from the IHI annual report, showing a picture in our unit, walking a patient with PT, CNA, and you know, I gotta put myself out there. I was a nurse, I did wear scrubs. I can wear scrubs, I gotta say. I was kind of proud of that moment, alright? So I can do it. I maybe can't chart an epic, we'll ask Christy about that stuff, but I can nurse. Okay, so this is a study this was one of the first studies published about safety of mobility in the ICU. And this was the group from the respiratory ICU at LDS Hospital. So Bailey was one of the nurse practitioners, was the lead author on it. I love this picture here. So this is one of the pictures of the unit, the old 8-bed unit before we moved to the new hospital. And what I'd love to show about this guy here is that he can do mobility. He's on crutches, he's walking around instead of a walker. Normally we went with a walker, but he's only got one leg. And he's doing early mobility, intubated. The RNs here, we got ART lines, Everything's hooked up, feeding tube, art lines, RT, PT, just going and getting him around. It can be done. The nurse practitioner who was in the video, the guy, had mentioned we've been doing this. The comfort level was there. You know, looking at the patient, we could go, okay, yeah, they are on the PEEP attendant at 90%. We'll walk that patient. It's not going to happen here. We're going the low-hanging fruit. We're starting with what's really safe patients to walk. But it is a safe thing. So they've had ICU. We want activity with all the patients. So we include patients that were on mechanical ventilation at least 4 days. Criteria, they had to have a neurologic response. Respond to verbal stimulus. So that's that RAS of -1. They didn't have to have a conversation. They didn't have to know everything that was going on. But they had to respond to that verbal stimulus. We started the trial with less than a PEEP 10 and less than a FiO2 of 60%, and then no orthostasis, not on pressors for these patients. So I want to make sure you guys know early mobility isn't just walking intubated patients. It's sitting at the side of the bed, sitting in a chair, and ambulating. That was our goal. The team is PTs, RTs, RNs, and a critical care tech. Outcome was to be able to ambulate 100 feet when they discharged from the ICU. So this study followed 103 patients. Kind of just a breakdown here, Apache scores of 26, multi-organ failures, their PF ratios, ICU length of stay, hospital length of stay. So we're talking 18 days in the ICU, 22 days in the hospital. So kind of long-term, you know, patients that weren't so simple to take care of. This is a list at the last day in the respiratory ICU, what activity they were getting. So only 2 patients of all of this didn't have activity the last day. Some were sitting on the bed, some were in the chair, some were ambulating less than 100 feet. Majority of those patients were walking more than 100 feet. So they surpassed the goal. So most patients, by getting that intervention early on and continuing to do it on a daily basis, were able to have this strength when they left the ICU. And if you notice, a lot of the women in that video went home. So yeah, they had oxygen needs. We took care of their needs when they were extubated. They still had their strength. So we were able to send them home even from the ICU on oxygen with a little support, but they didn't have to like start all over. The key about this study was to talk about the feasibility and safety of it. Not necessarily looking at the outcomes, but making sure it could be done. No one had done a study. No one had published a study for it. So there were 14 adverse events out of 1,449 activities. 5 were falls to the knees without injury. 4 systolic blood pressures went below 90. 3 oxygen desaturations below 80. 1 small bowel feeding tube came out, and 1 systolic blood pressure over 200. 14 less than 1%, and none of them were big problems. You know, we get scared of the patients. We're like, what about the tube? What about this? You got a team there. You have an RT that their focus is on the ET tube. You have a physical therapist focused on the body of the patient. You have a nurse focused on those tubes and lines. So it can be done safely. It is feasible. We've done it here. So a couple years ago we talked about this. We started working on our mobility. This guy Nick was great. He was in his bed, awake, on his ET tube. We found out the best way for him to communicate was his iPhone. He'd just be able to text and do that. Wouldn't that be great? Your patient can actually talk to you instead of like try to word it, you try to play charades, it doesn't work so well. He can go, I have pain, or whatever it was, I need to go to the bathroom. Instead of you just coming in and finding out they went to the bathroom and had to clean it up later, right? So you did it here. I just want to talk about the feasibility. There wasn't big staffing changes in the respiratory ICU. Still had a 1 to 2 nurse to patient ratio. RT now, this RT ratio we had 1 RT in for an 8-bed unit. So it really was a 1 to 8, or I'm sorry, that's RT. PT wasn't a 1 to 8. RT was just their regular assignments. So it did take time out of their day, but it was their regular assignments per bed. But we're not the only people that took a look at this. So Schweikert does a lot of research on early mobility. did a randomized controlled trial looking at physical and occupational therapy. So what they did is they started looking at doing their therapies early. So in their protocol, they started seeing their patients were about the same, randomized to it. So Apache scored 19 to 20, no big difference. But the ones that were seen by PT and OT, 1.5 days compared to 7.5 days. Out of bed within 2 days, out of bed within a week. They were standing in 3.5 days, standing in about a week, and walking in about a week, walking in about 4 days. So when it's on your mind, when it's on your radar, look at those interventions we can get in. We saw the atrophy of those 10 days, right? Muscle atrophy, look how fast we can nip that in the bud instead of letting 6 days go by. So we can save our patients a lot of torment. And this is just looking at their studies. So ventilator-free days, ICU delirium days, length of stay. So the parts that are statistically significant. Length of stay was 2 days less in the ICU. Hospital, it was about half a day, so they still went to the floor. There's some other research to look about after they go to the floor, when you get the high intensive in the ICU, but then you kind of lose some of that when you leave that, when you walk out of it. And mortality. So just some great stuff from their study when it was just all talking about getting early PT and OT. So is it safe? Morris does a lot of research on it also. So there were no adverse events in their group. 1.4% of passive and active sessions were not initiated because of either a high or low blood pressure. So very few weren't done. Less than 1% of sessions were not initiated because of too high or too low heart rate. Most frequent reason for ending a mobility session was patient fatigue occurring without a significant change in the patient's vital signs and no accidental removal of device. So, all of a sudden we're starting to show, research can show that it's safe to move ICU patients. Same type of thing, Schweikert with his follow-up, almost 400 physical events, 0 falls to the knees, 0 systolic changes, 1 oxygen desat, no changes in blood pressure over 200, no unplanned extubations. It can be done. What about the benefits? So on post-intensive care syndrome, so it decreases delirium from 2 to 4 days, decreased delirium duration, 53 days versus 31 days, decreased ICU length of stay, 7 days to 4.9, and these are all just different studies, and their outcomes that they measured for early mobility. Hospital length of stay in Needham's study was 17.2 days to 14.1, so that's 3-day difference in how long they've been in the hospital. Decrease in ICU length of stay in this study was about half a day, and the hospital was almost 3 days. Decrease in mechanical ventilation, so you're a day less on the ventilator. In the ICU, you're looking about 2.5 days less in the ICU, 3 days less in the ICU. So huge impact we can have on patients, especially in the ICU. Now, you will notice a lot of times the ICU is the big difference. That might be your 3 or 4 days different, and they still spend about the same amount of time on the floor. It's a little different. One of the things you got to look at is the floor ratio doesn't change, the workload doesn't change out there. So they get the intensive therapy, the intensive work from us in the ICU during that time. Huge impact though on what these patients are going to do. So we took some tools, the system has a few tools, and we kind of took a look at them here in our ICU. And this is the mobility screening algorithm that we have. Now, we have these tools, you guys have a copy in front of you, but on our MICU webpage under resources and under ABCDES, these tools are available as well as the mobility protocol. So it's all about screening your patient. So you want to take a look, what can they do? So green is they're good to go. Yellow, let's be careful about it. Red, or we're a little concerned about doing mobility on them. So just kind of what they're able to do and have these conversations. Rounds is a great place. Is your patient good to go? Are we green with this patient? Do they have that RAS of -2 to +1? Are they cleared spinally? No neurodeficits? No ortho injuries? If they're intubated, we're looking at a PEEP less than 10 and an FiO2 less than 50%, that low-hanging fruit. And then what the mobility is. That's great, I want y'all to be aggressive, but you don't have to run your patient out and take them down to the shower day one. Let's just see if they can sit up. And PT is gonna talk a little bit about kind of as we move on there. But look at these things, but it's also, oh no, we're yellow, we're not gonna do it. What can we do to move from yellow to green? How can we use that algorithm? So these are levels of mobility, so on the back side of that. So passive range of motion, this is that patient that's sedated, non-responsive, RN, you're turning them every 2 hours. Let's do some range of motion. Let's help them out somehow. But we want to see what we can do also to move them up, right? And then first step is sitting upright, dangling, out of bed, ambulating. Any questions on that? I know I kind of did a quick run through of it. And we have, these should be conversations we're having in rounds. So when we're going there, what's our patient at? What level are they at? What's their activity plan today? Because we want to see, this just kind of talks about progressing it, which is pretty simple, but so I'll just kind of skip over those. What our next steps are. What are we going to do for our patients here in the medical ICU? How are we going to move them? How are we going to decrease sedation? How are we going to get that there? So a lot of goals we're looking at, we've been talking about we want patients off their sedation at night so that we can do an SBT in the morning. It's awesome and cool to take a nice video of a patient on an ET tube walking down the hall with a group of people around them. It's so much better if they actually don't have that ET tube and you don't need that whole group of people and they only need 1 or 2 hands to help them out. So SBT is a great thing to do, so we want to get that sedation off, do the SBT. Now I'm getting new data from Mike as of this morning about what that sedation is and getting extubated, so we'll kind of take a peek at that. But our goal is, if you're working night shift and you've had them sedated, get that off. So in the morning they can be up, awake, in the chair before rounds at 9 o'clock. That's what we'd love to see. RT, they don't want to walk patients, let's be honest. That's a lot of time. They're going to work really hard at getting that patient extubated. And we actually saw that when we first did mobility a couple years ago, before a lot of you may have come to the unit. The RTs were like, oh no, we're ready. We're ready to extubate. They were just jumping on that. Awesome, even better. I like that. Also, one of our goals is we want to push to walk two patients that are eligible A. We'd love to see them walking. Those ones are low-hanging fruit. If we don't have patients that can't walk, even better. But I know we have a few of them on those vans, a few of them that need this therapy. Let's see, what else? Any questions? I know I ran through them pretty quick. So next thing is we're going to do is we're just going to talk about kind of these steps of mobility. So I'm going to turn time over to PT to just talk about that. A lot of it, I am concerned about you all. A lot of this is moving patients. We're not all trained on how to actually move patients. We've had a lot of injuries, right? We've had back problems. We've had pulling issues. So I'd love, as we're doing a lot of these things, we're trying to dangle, we're trying to position the patients. I'd love to learn how to do it safely from physical therapy so we can be a great help to our patients, a great help to them, and to not hurt ourselves. Let's help patients, let's not harm ourselves, let's not harm patients, and let's have some great outcomes.